Hello everyone, and thank you so much for dialing in for the webinar tonight. Before we get started, the Western New South Wales Primary Health Network acknowledges that we work on the traditional lands of many Aboriginal clans, tribes and nations. I would like to pay respects to elders past, present and emerging, and acknowledge the traditional custodians who care for this land on which we work and live. I acknowledge and respect their continuing culture and the contribution they make to the life of the communities in our region. So we'll just go through a little bit of housekeeping before we pass over to Dr. Williams. This webinar is being recorded and we will endeavour to make the recording available. Anyone who attends the webinar usually gets a link to that, and for those who might not have been able to attend, we will aim to put it up on our website as soon as possible. Also, at the completion of the webinar, there will be a short survey that comes up just asking you about any further learnings that you might have and any comments. So please take a short while just to fill that out for us. We always appreciate your feedback. Now, if you're new to webinars and you haven't done this before, your toolbar should be in the top right-hand side of your screen. If you can't see it, you just press the little orange arrow and it should open up the toolbar for you, and then you'll be able to see your panel. During the webinar, everybody is on mute, just so that we optimise the sound quality. If you want to ask a question, either use the chat or the question boxes, and Dr. Williams will aim to answer as many questions as he can at the completion of the webinar. Any questions that we can't manage tonight, we'll certainly take on notice and try to send out to everybody as soon as we can. I'd also like to thank Dr. Williams, who's the infectious disease specialist at the Western New South Wales Local Health District here in Orange. We really appreciate him offering his time and expertise this evening, especially amid such a busy and demanding time. And without further ado, I will pass over to Dr. Jacob Williams now for his presentation.
All right, so thank you, Katie, and thank you everyone for joining tonight. I appreciate that you've all taken the time to be here and to listen to this presentation when you could be taking a break from COVID-19, which I'm sure is taking up a lot of your working hours and your non-working hours at the moment. I just want to take the opportunity as a hospital-based doctor to really acknowledge the work that the general practice and community health colleagues of mine are doing at this time. You know, we don't get the opportunity necessarily to engage with each other as frequently as we all might like, but I just wanted to say that we see you out there in the community and in the hard work you're doing, and we're incredibly grateful for all your support during the preparation period for what's likely to be a very long and challenging winter for ourselves and our patients and our community. So I just wanted to start really macroscopic, and then I might zoom in a little bit more. So, I mean, everyone uses the word coronavirus to talk about the epidemic, the pandemic that we're currently facing. But obviously there are lots of coronaviruses, and what we're dealing with at the moment is a novel or a new version of that group. So Coronaviridae are enveloped RNA viruses. They predominantly actually affect non-human mammals and birds. Only very few affect humans. They're globally distributed, they're everywhere, and essentially the Coronaviridae that affect humans generally cause the common cold. So those of you who may have ordered a respiratory multiplex before may have seen coronavirus OC43, 229E, and these are endemic viruses that circulate throughout the community, particularly, you know, through the school and young children population, and they're not necessarily uncommon. They're called coronavirus because of the scanning electron microscope appearance you can see on the right there, where the viral proteins that envelop the outside of the virus have this sort of radiating appearance, and similar to the corona of the sun. So we've been in a situation similar to this, but somewhat easier to deal with before. So in 2002, a novel species of coronavirus emerged in the Guangdong region of China. The most likely method of transmission was from bat to human. Bats are implicated in all the novel coronaviruses because the majority of those species do affect bats. But it was able to make the jump and then develop the ability to do human-to-human transition. And of course, that virus, when eventually typed and identified, was called Severe Acute Respiratory Syndrome Coronavirus, or SARS-CoV. That was found to resemble a number of other bat-related viruses, and these are all grouped together under the SARS-B coronaviruses, which falls within a wider envelope of beta coronaviruses. You can see some very innovative naming from my microbiology colleagues. And so MERS, which we know is similar to SARS and similar to the SARS-CoV-2, which is the virus that causes COVID-19, is similarly related but falls in a slightly different subgroup. That's from clade C, whereas SARS-CoV-1 and 2 fall within clade B. And so the SARS-CoV-1 caused the SARS epidemic, which in 2002 claimed a number of lives, particularly in the Western Asian region of the world. And the way we were able to really get on top of that was that there was a significant public health and quarantine effort, but there were elements of the SARS epidemic that are different to what's happening now that made it much easier to manage. The most important, I think, is that patients with SARS were not infectious until they became symptomatic. And from a public health point of view, that made things relatively easy to manage because you just had to find people with symptoms. And if they had no symptoms, then you could easily exclude them. And we know now from our experience with SARS-CoV-2, the virus that causes COVID-19, that there is likely to be a pre-symptomatic infectivity period, which makes the public health response much more challenging. So, some of you may be familiar with the history. In December of last year, a number of cases of viral pneumonia presented to a hospital in Wuhan, in the Hubei region of China. These cases were all epidemiologically linked through the now famous Huanan seafood market. They eventually managed to cohort these cases together and realized they had an emerging problem. And so one of these cases went on to have a bronchoalveolar lavage specimen, and they had developed at a local reference laboratory this pan-beta coronavirus PCR to kind of develop to sort of used in case of a SARS-like pathogen emerging. And when that was positive, it immediately became apparent that they were dealing with a novel pathogen because the SARS tests were negative, but the beta coronavirus PCR was positive, which implied that this was a novel pathogen they'd never seen before. The next day, the WHO was alerted and the Chinese CDC went out to investigate. And so this is a rough timeline of the outbreak in its early phase. So you can see that in the early phase there was a number of cases who were already symptomatic but were yet to be truly identified. So when they've gone back and looked retrospectively, you can see that in this early phase of the epidemic there were people with symptoms they weren't able to identify until here, this late December period. And by that stage, because of the number of cases that had been able to move throughout the community, things are already kicking off. So we all remember, I think, the time when Wuhan City at around Chinese New Year was shut down. And this is the early pandemic response from the Chinese government. And then it wasn't until, by that time, things were already well out of hand. By late January, there was already a clear nationwide problem within China, and things really started to escalate from there. This is now the epidemic curve, which is sort of what we were dealing with in that last slide is kind of this phase around here into early January. You can see now it's orders of magnitude higher, and in the early phase it's almost exclusively disease limited to China. Whoops, sorry. There we go. And you can see the epidemic moves through phases. So there's this period here, as early as a couple of weeks ago, where you might have seen the WHO president saying that the epidemic is now centralized in Europe. But in the last few weeks, the United States has really ramped up its testing capacity, and its ability to identify its already existing high levels of disease has increased, its overall case burden representation has gone up as well. So I make a point of every time I give a talk about COVID-19, I include a trajectory of the slides that I've used about the state of the outbreak. You can see the first time I gave a talk on this topic to a large audience on the 10th of March, we had 114,000 cases and 4,000 deaths. I gave a grand rounds a week later when there were 170,000 cases and 6,000 deaths. And this is this afternoon's slide. 423,000 cases worldwide and 18,000 deaths. So, I mean, this is the nature of the pandemic and the nature of exponential growth of infection. The doubling time in Australia is approximately between 3 and 4 days at the moment. So the numbers you see will escalate rapidly. So we had 1,000 cases on Sunday. We now have almost 2,000, perhaps by now more than 2,000, and the numbers will continue just to double in that fashion. And so there are glimmers of hope within this. If you go back to my previous slides, you can see South Korea, when I first gave this talk, had 7,000 cases and 54 deaths. Over time, in a week, they only had 1,000 extra cases, which would mean they'd managed to slow their doubling time significantly. By today, they're not even in the top list, and South Korea and models like it is what Australia is currently looking to in terms of its control and case finding in how to manage the already escalating problems that we've got. This is New South Wales Health data from yesterday, looking at the number of identified cases in the state. And you can see a slow shift in the epidemiology where a majority of the cases, certainly early on, are exclusively imported. Here is the darker green bar represents people who are locally acquired, but you know where they come from. And this is the more concerning bar here. So this bar, which is getting steadily larger over time, are cases that are acquired locally from an unknown source. So essentially that is community transmission. And although as the Chief Health Officer and others have said, a large proportion of our infections are significantly imported from overseas, my main concern as an infectious diseases doctor is how big in absolute number this bar gets, because this bar is not captured by our case definition. So this is the age and sex distribution across New South Wales. You can see that it's kind of representative of the type of population who imports infection rather than local transmission rates. There's a relatively even gender split, but a predominance towards younger people in the 20 to 50 age bracket. And it's probably why, although we have a significantly large number of cases in Australia, our mortality rate looks relatively strong compared to a lot of overseas experience. So Australia, when I last counted, had 6 deaths in almost 2,000 cases, and that's certainly well below what's quoted in the literature overseas. But it's probably a function of where we're at in our epidemic. But if local transmission escalates and resources become stretched, then we're likely to see that mortality rate change. So I wanted to zoom in on a bit of local data. This is the testing data for our LHD, so Western New South Wales LHD, and this is an absolute number. So this is the absolute number of tests that we have done for COVID-19 since the outbreak started and data began to be collected. Northern Sydney and Southeastern Sydney are the centres of a number of outbreaks, cluster outbreaks in Sydney. Northern Sydney LHD is part of the Macquarie Park area, and Southeastern Sydney is part of the airport chain and has a large overseas student population as well. And so they're testing in very high numbers. But actually, this is probably relatively appropriate for the amount of population that we have. So if you compare our testing numbers in absolute sense to our population, we're about the same. The graph was ordered oddly, but basically, we're about the 5th smallest LHD in terms of population, and we're about the 5th most common tester as well, which I think is very appropriate, because even though our epidemiology might be different and our caseload might be different from Sydney, one of the messages I want to take away from this is, particularly in the next few weeks, we should be expanding our use of clinical judgment in the people that we test. So this is the case definition, essentially. This is just to refresh the people who currently mandate a test, so it should absolutely be tested according to New South Wales health policy. Obviously, the EPI criteria remains the same, either international travel or a close contact, or fever and acute respiratory infection. That is the A criteria. Then there is also, as you can see now, that is the most commonly known and the most widely used. The next is the B criteria, which we use commonly in hospital. So bilateral severe community-acquired pneumonia and no other cause identified. And certainly we are testing a number of cases who meet that definition. And also the C criteria. So any healthcare worker with direct patient contact and a fever above 37.5 and an acute respiratory infection. That is actually a suspect case as per the case definition and should trigger a test. This is the definition of a close contact. So there's this, if you have a close contact with a proven case and you develop symptoms, you mandate a test. And so these are all the settings in which one could be considered a close contact. And the ones that we see used most regularly are 15 minutes of face-to-face close contact, sharing of a closed space for more than 2 hours, living in the same household, or longer than 2 hours in another. That circles back to the same, longer than 2 hours. And also a person in a hospital room when an aerosol generating procedure is undertaken without recommended PPE. And the important thing about contact tracing is that it needs to have occurred within the period extending 24 hours before symptoms onset. So if you see someone in your practice on a Monday, they develop symptoms on Thursday and they're positive on Friday, you are not a close contact and you do not need to isolate yourself or manage your movements in any additional ways. So before I go into transmission, I just want to talk about the case criteria a little bit more detail, because those of you who are familiar with the New South Wales Health website might see that there's a little bit of discordance about the case definitions. So this is the case criteria that is set by the Commonwealth body, so the CDNA, and New South Wales Health simply ports that across to their website as the case definition. However, if you go to the New South Wales Health website and you look at advice for healthcare professionals, there is a whole other set of criteria for situations in which a test would be triggered. It basically involves an expansion of the close contact criteria to essentially anybody who is at high risk or associated with a cluster. So for example, if you have a patient who's come off the Ruby Princess and they don't necessarily have close contact with anybody who was proven, you still need to test them because they are from a high risk cluster. Other examples of the additional guidance for healthcare workers is every acute respiratory illness admission to hospital. And so I want to stress that at the moment, we're essentially screening every respiratory admission to Orange-based hospital for COVID-19 and managing them in a specific respiratory ward in order to keep with that guidance. And yes, it uses a lot of PPE. Thanks for asking. So this is the knowns about transmission. So we know that in normal circumstances, the virus is transmitted by a droplet, but you can aerosolize it. And the thing I want to stress about aerosolization is that it's not necessarily a matter of normal respiratory illness. So when you have a patient in your rooms or a patient in your practice, they generally do not aerosolize virus in a volume significant enough to cause infection. The way you can aerosolize the virus typically is iatrogenically. So any outside application of pressure has the risk of hitting the droplet and blowing it into aerosols. So that's things like nebulizers, high flow nasal prongs, non-invasive ventilation. All these things can trigger an aerosolization of the virus and mean that healthcare workers who are using normal standard procedures, so a surgical mask, can theoretically be infected. The other concern is that aerosolization lingers in the air for longer. So if you are doing an aerosol generating procedure, and we do them regularly on these patients in hospital when we intubate them, you have to leave the room empty for 30 minutes to allow those aerosols to settle before you then go on and do your environmental cleaning. But in a community setting, in a general practice setting, the major aerosol generating procedure that I think people need to be aware of is the collection of samples. So although it's not an iatrogenic application of pressure, the amount of, the stirring up you do and the likelihood of the patient coughing significantly and the amount of sort of force sometimes applied means that it's considered at the milder end of AGPs, but we do recommend that when you're collecting a swab, you do use an N95 mask. Although I'd stress that it's not as high risk as any other outside pressure application. Fecal shedding is a concern for COVID-19, particularly in children. We can detect the virus in stool. What we don't know is whether that's insufficient amounts or the virus to infect someone else, or whether that virus is even alive. But certainly it's important to be mindful of that when you're dealing with children who may have a possible infection. There's good data from a Singaporean group that says that once it lands on a surface, it can live for about 72 hours. And so it's important to be mindful of your environmental cleaning. So things like desk phones, computers, desk surfaces, these are the sort of things where if a droplet lands on it, it will persist. And if you pick it up on your hand and then you touch your face, that is how you get, remote infections through mucous membrane infection, penetration of fomites. The way you can manage this is you don't necessarily need to disinfect everything in your practice, but simply a wipe with detergent, neutral detergent wipe, or any other household cleaning will be able to remove the organic oils and surfactants that allow that virus to thrive. It will help to debulk the area from the grime and dirt that it loves. If you are going to disinfect an area after a patient interaction, either you've collected a sample, or you've got a positive patient, or you're running a fever clinic, standard disinfectant is fine. So things like Chlor-Clean, household hospital grade disinfectant like Glen 20 or what's that other one? Dettol, all that stuff is appropriate. There's Commonwealth guidance in that area. So if you're interested in the environmental cleaning, you can look on the New South Wales Health website and they'll give you some tips about the kind of concentrations you can make up or use. What we don't know about the transmission is these things. So what is the true R0? So we have a reasonable, and R0 is an epidemiological term for the basic reproductive rate. So if you get COVID-19, on average, how many other people will you give COVID-19 to before you recover? And obviously for the virus to propagate, that number needs to be greater than 1. But every virus is different in terms of its general infectivity. So rhinovirus has an R0 of approximately 6. That's why it's so common. Measles has an R0 of over 15, which is why it is so great there is a vaccine. We estimate that COVID-19 has an R0 somewhere between 2.5 and 3. That is, of course, in a natural environment, and by socially distancing and removing your interactions with others, you can lower your R0, and hopefully if we can do that as a population, we can flatten the curve, which I'll talk about in a little bit more detail later on. What we don't know really is also what the R0 is in children. So you may have seen a lot of discussion in the media and in scientific circles about the closure of schools. Now, I am not an epidemiologist and I don't have access to the modelling to make a truly informed expert call about the closing of schools. But what I will say is this: part of every pandemic plan for influenza in the world is closing schools, because we know that with the flu, schools are hotbeds of spreading infection. The data, although not robust, and I'll give you that, does not necessarily support that a closure of schools will significantly impact the spread of this virus. Now, I know that's a very charged area and an area where there's a lot of discussion, so I won't make further comment on that, but suffice to say that I don't have the necessary information to make a truly informed comment about it. The other thing that's really going to be concerning is what is the pre-symptomatic infectivity phase. So as I said before, we contact trace backwards from 24 hours before symptoms started, but we know that the viral shedding is extremely asymmetrical. Those of you who follow along in the mainstream elements of our media would know that Richard Wilkins has coronavirus. Richard Wilkins has no symptoms, according to Richard Wilkins, and he's had 3 tests across the last week, all of which are positive. Now, if there were, say, 100 Richard Wilkinsons running around in the community, from a public health perspective, that's very bad, because we've got people who are theoretically asymptomatically spreading, which is exactly the reason we could get on top of SARS and exactly the reason why we can't get on top of this. The problem is, 1, how common are those people? 2, does a positive PCR of your nose actually mean you can infect someone else? And 3, when does that change? You know, how in the, because at the moment all our tests are qualitative. They're a yes/no test. We don't have an idea of this much virus, that much virus, dead virus, live virus. It's very difficult to manage it. The third thing is, what is the value of a negative PCR? And some of you may have seen a lot of concern generated by one of the early cases in Sydney where someone who was critically unwell in ICU had nasopharyngeal swab after nasopharyngeal swab after nasopharyngeal swab, and all those swabs were negative. It wasn't until they did a lower specimen through a bronchoalveolar lavage and a blood PCR, which they did in research capacity, that they eventually proved that yes, this person who they were absolutely sure had COVID did in fact have COVID. Now, if you take that story as an anecdote, which you really shouldn't, because anecdotes are dangerous, you understand the challenge we face when you have someone in your office who you think may have had exposures, but they have a negative test. Well, what does that mean? How confident am I in telling this person that they can go out into the community and go to Woolworths? Or how confident am I that, I'm not about to start a local cluster by sending this person home? And I think ultimately my comment on that is we have to build a system that works and recognize that anecdotes are not proof of a phenomenon, and overwhelmingly the advice is at the moment that a negative PCR of a nasopharynx is enough to say that at the very least this person has almost no chance of having COVID-19, and two, even if they did, we would have absolutely no way to tell whether or not they were infectious. And so the third thing is viral shedding and infectivity, which I guess I've covered off earlier in that discussion. And this is just a slide to illustrate that problem. This is a Singaporean cohort. I'm sorry if it hasn't projected very well. Essentially, this is 18 patients who were admitted to hospital in Singapore. And the plus sign indicates when they were admitted to hospital, and they essentially tested them regularly. A red dot indicates that they were positive for COVID-19. A white dot indicates there wasn't a test and done that day, and a green dot indicates they were negative. The fill indicates whether or not they had symptoms. So a green person is symptomatic and either febrile or afebrile. A yellow person or an orange person needs oxygen, and a blue person is better. So as you can see, there's a huge amount of variation in the patterns of their test. This person came in, they were really well. This person came in, they're really well, positive. They're totally better, but they're still positive. Oh, and they're negative the next day, but they're positive, even when they're better. And so this is, again, a real problem when it comes to managing people who are positive in the community. When can we tell, even when they're better, how long they're infectious for? And it doesn't stand up to our usual viral policy, which is, for things like flu and rhinovirus, when you're better, you can go back to work. And I'll talk more about the public health implications of that later on. So I just want to talk about the disease itself very quickly, recognizing that we've only got a limited amount of time. So this is some data from the cohort in Wuhan, about 1,000 people who were admitted to that purpose-built hospital in the middle of the pandemic. And they collected some data about their presenting features. So in a majority of cases, fever was present, so about 88%, but only half of those were present at presentation. So less than half of the patients who were admitted to hospital with COVID-19 had a fever when they came into hospital. And that, I guess, harks back to my concerns about the case definition where you say, oh, well, test healthcare workers, but only if they have the fever above 37.5. Well, one, temperature of 37.5 is not very helpful when it comes to diagnosing COVID-19. And two, when was the last time a healthcare worker took their temperature before they came in to work if they were sick? So in Orange, certainly we're being very defensive with that healthcare definition, and we are testing a majority of healthcare workers who have upper respiratory tract symptoms. And that's an operational decision we've made as a hospital because we have a very fragile workforce. It's very low in number. It's relatively cohabited. We have the same childcare. We have the same schools. We all back in the old days, we socialized together. And so we're very mindful of if we miss one, then it's going to have significant implications for our patients and for us. Non-productive cough was the most common other symptom, but in essentially everything else, malaise, breathlessness, productive cough, diarrhea, happened less than half the time. And so essentially, even in the setting of a pandemic, when everyone in hospital had COVID-19, it was still extremely difficult to work out what a typical COVID patient looked like. And that's what makes it so challenging in the community and in hospital. The radiology, however, is slightly easier to to describe in its typical way. And I'm going to hope this works. Bear with me. Oh, that's not good. Oh no, here we go. Great. So this is a video, and I hope you can see it. Let me just open up this one. Yeah, I'm going to
check audience views and
triangle. This one. This one. Perfect. Oh yeah, great. So I'm just going to check here and play. So you can see diffuse ground glass opacities throughout both lungs. Predominantly, though, they are peripheral, and they are sort of with a minor basal predominance. You go further down. And so this is why in the Chinese cohort, and you may have seen this described, the CT scanner actually became an incredibly useful tool in the fever clinic. What they would do is do a swab and then put someone who had a high risk story through the scanner, and if they had these features, they admitted them. Now that is no longer, it's not the view basically of the majority of international experts that is an appropriate way to triage people. Certainly it worked for them, but it's not what we are advocating for at this stage. There is a minor utility for CT scans, and I'll talk about that here.
Orange.
Oh, that one. Sorry. Talk about that here. So essentially, the role of imaging in COVID-19 is about progress and diagnosis. So essentially, you want an early chest X-ray. Obviously, no one really has access to lung ultrasound. An early chest X-ray in hospital setting in order to determine if they have the appropriate infiltrates. And then once they really get off and kicking and they're in hospital, there's really not that much utility to doing it. And so what I would stress in the community setting is there's really not much utility to doing chest X-rays for people who you suspect have COVID-19. Certainly, it's not necessarily going to change your management. It's going to be a higher risk procedure in terms of being able to warn the local radiographer that it's happening. And they all have clear chests, and they don't necessarily require imaging in order to make a diagnosis. Either in the pre-test, the current phase where we have a very low case burden, but even in the pandemic, you wouldn't necessarily use it. So laboratory features, there are a few things that are common, but you may notice from looking at this list, the only things that are common are the things that are completely non-specific. So lymphopenia is the most strongly associated, and doesn't necessarily need to be frank. It's usually around the low ones. CRP predicts a more severe course when you take all comers. I think that stands to reason, essentially, that if you meet 1,000 patients with COVID-19, the ones with higher CRPs do worse. Similarly, LDH and ferritin are also correlated with a more higher likelihood of ending up in ICU, and I'd say that's probably true of most patients, regardless of their disease process. There is certainly, though, a strong signal of adverse cardiac outcomes. So we know that troponin goes up as these guys get worse, and again, that stands to reason, but certainly there is a high proportion of arrhythmias, so 12 to 15% of admissions to ICU in a Wuhan cohort were for arrhythmia rather than respiratory failure. The number of sudden cardiac deaths in this group is high, and there's signals at post-mortem both of viral cardiomyopathy, but also on serial ECGs of QT prolongation and ischemic change. We also see things like DIC and HLH, but overwhelmingly typical features, the typical viral ERT symptoms will be more common in the early phase of the outbreak. So this is what makes dealing with COVID patients in a hospital setting or even in the community so difficult. They have this sort of biphasic trajectory, not unlike someone who has, like, say, a dengue or an arbovirus. And if someone comes into your practice on day 4 of their illness and you diagnose them with COVID-19, rarely are they actually in much danger at day 4. Where they actually fall into trouble is this day 7, 8, 9, where a majority of patients, because a majority of patients have a mild self-limiting illness, will get better, but a minority of patients will do extremely poorly and do extremely poorly extremely quickly. And so the progression to rapid respiratory failure typically takes place around this day 8, where they generate a large amount of hypoxia, which is often disproportionate to their work of breathing. So this is kind of like almost like a pneumocystis phenomenon where people will be sitting in bed like, no, I'm pretty good actually, I can't just go to the bathroom, but they're sat for 85% on room air. And then they eventually progress to extremis, and then they become difficult to ventilate and often have a very high mortality in ICU. The rate of superinfections and the microbiology of superinfections is still, that secondary bacterial infections, is still under discussion. There's certainly not a high signal for Staph aureus like there is in flu, and not a high signal for Aspergillus like there might be in the other populations. So it seems to be that if you think they've got a secondary pneumonia, typical community-acquired pneumonia or hospital-acquired pneumonia treatment might be appropriate. And so that's what really makes the management of these guys in hospitals difficult, or even, and again, in the community, very difficult, because you're trying to risk assess who is going to do this, where at day 4, they've got bilateral infiltrates that look like patchy ground glass on the left, and on the right, it looks like it's improving at day 8, and this, who at day 4 has those infiltrates, and at day 8 has that infiltrate. It's extremely difficult to know. There are some things associated with those poor outcomes, and some of those things I've talked about earlier, so things like a higher CRP at presentation, lymphopenia. But in terms of the patient population, overwhelmingly, it's things like the older population who have a background of cardiovascular comorbidity, those who have an underlying immunosuppression. But one group I think that's particularly not vulnerable to this is pregnant women. So pregnant women do not have an increased signal of mortality or severe disease if they get COVID-19. There is certainly no signal towards miscarriage or birth defects. There is a small signal about an increase in premature birth and low birth weight. That will require a more robust number of cases in order to truly describe that. But overwhelmingly, we don't have the signal amongst pregnant women that they are more susceptible than age-matched cohorts for severe disease. Granted that, of course, in every age-matched cohort, so even in anyone, pregnant or otherwise, who's 25 to 35, there is a risk of progression to this pattern of severe disease, somewhere in the order of 0.2 to 0.9%. So I want to talk a little bit about treatments, and I'm interested to get some feedback about whether or not these are things that people have spoken to you guys about in your community. So lopinavir, ritonavir, or Kaletra, for those of you who have a bit of HIV experience, showed a great virological response in SARS. There was some early studies on using it in Singaporean cohort, and the concern then was that they weren't using a high enough dose because the effect was poor. Some of you may have also seen there was a large study out of China recently where it was also not looking very promising, but the feeling is perhaps that it was given too late. It may be like a number of other virus treatments that by the time you have actual disease manifestations, particularly ARDS, the horse has bolted, and maybe we should be giving it to people earlier. The other is hydroxychloroquine. So hydroxychloroquine is chloroquine is an antimalarial. Hydroxychloroquine or Plaquenil is used in rheumatoid, SLE, and it has some in vitro data saying it has it's very good at inhibiting the viral replication of SARS-CoV-2. And so there's a lot of interest in this. It's been recommended by some overseas expert groups, but there's no data. Concerningly, though, there is a large signal, and some of you may have got some PBS advice or some TGA advice this week, that there is a large proportion of people in the community who are asking for or stockpiling this medication off-label, including a large cohort of medical practitioners who are using it as pre-exposure prophylaxis. I want to take the opportunity to empower you guys as clinicians to say that kind of behavior is absolutely inappropriate and dangerous. So these, particularly when used in combination with azithromycin, as you know, President Trump might have tweeted about in all caps, that study was extremely limited in its methodology. It is not proven, and if you are taking a QT prolonging drug like hydroxychloroquine with a QT prolonging drug like azithromycin in a disease that is known to give you a risk of arrhythmia, that is not safe, and it absolutely should not be done. And if you ever get inquiries about that, I'm happy to be spoken to and have the person directed to me. So this is some in vitro data, as I've talking about the effects of lopinavir, ritonavir on a SARS model. Suffice to say that there's relatively strong virological effects in terms of this is the control group down in B and this is the treatment group. It has not been borne out in vivo though to date. And so that leads into a larger problem about data. Everyone's really interested in this idea of, well, you know, we know this about COVID because of what happened in China. We know this about COVID because of what happened in Italy. But ultimately, in day-to-day practice, we wouldn't look at single-center retrospective cohort studies and say, yes, that is the absolute truth about this disease. We are changing the way we treat the information because it's the only information we have. But I want to stress that, there is actually not that much certainty in terms of evidence-based medicine about the things we're seeing. And we're already seeing some of the signals that came out of those early studies not match up with what we're seeing in other parts of the world. So the case mortality rate looks different in Italy than it does in China. The population affected severely in the US looks slightly different to that in China. And so it's very difficult to say truly what this will look like on a global scale, and particularly what it will look like locally. So that's all very, a lot to take in, and I'm sure that you don't need my help in feeling concerned about what's going to happen over the next few months. I just want to focus a little bit on what we're doing as health practitioners, and certainly what we can all do to support one another. So we can't necessarily control things like how well New South Wales government controls people who get off cruise ships. We can't control things like how well our community abides by social distancing. We can model that behaviour. We can certainly correct that behaviour where we see it done poorly, but ultimately it's not inside our locus of control. What we can control is how we care for people, how we prepare for the demand that we're going to have to face, and how we keep ourselves safe and keep ourselves healthy over the next few months. Because I'm really mindful of what other countries refer to as secondary victims of this epidemic. Settings where healthcare victims are so stretched, doctors are so swamped that the blood test doesn't get checked, or the appointment gets pushed back, and we're impaired from doing what we would usually do, which is care for people in our communities with chronic conditions, with healthcare needs, and help them feel supported and looked after. And burnout of healthcare workers is a real concern in this setting. I'm sure everybody's had a very big month and a very big, maybe longer than that. And I was staring down the barrel of, as I said earlier, a very long winter. And I'd encourage you all to reach out to one another, reach out to your colleagues, talk about it, talk to your family, because even though nothing's necessarily happened yet in terms of local disease activity on the ground, anticipatory anxiety, this fog that you see around everybody, is real, and it has a cost. And so one of the ways we can dispel that cost is by sharing the burden. I want to talk, that spins a little bit into about epidemiology. So I'm sure everyone's seen this picture, or heard of this concept of flattening the curve. This idea that if you don't control the epidemic and quarantine suspect cases early, what you'll have is that a virus moves rapidly throughout a population. And so because it moves rapidly throughout that population, the peak comes early. So there's a number of people who are infected very quickly. And because the number of people who need care over time will generally be close to fixed, it's not totally fixed, but it's close to it, you'll get this rapid upsurge, and the ability of the health services to deal with it will be quickly overcome. And that's where you end up with things like secondary victims, people who don't get the surgeries they need, or people who get discharged prematurely because they've got to make space in the hospital for these COVID patients. Ultimately, what we want to do is spread that out, so slow that infection, make sure that we are able to deal with things, deal with whatever infection rate happens in the community in a staged way, with a good plan and with capacity to meet it, and so that the amount of things that exceed our capacity is much smaller. Also want to stress that this point is not fixed. We are, as a health service, able to surge. Elective theatres are stopping tonight. PPE will be stockpiled, ventilators will be moved around, staff will be called back from leave or redeployed, and we can raise that bar. And that's what's happening in the hospital system, and it's the same as how we can view our resources in the community. So I just want to illustrate this point about the importance of social distancing as quarantine and quarantine using an excellent infographic from my friends at the Washington Post. So in this simulation, everybody who's blue is unaffected, everybody who's orange is infected, and everybody who is eventually purple is recovered. So this is what things look like with no controls. You can see that eventually this too shall pass. Everyone will recover until, of course, we do it all again next winter. But you can see the peak comes and then drops off in a relatively uniform way. This is what happens when you're able to quarantine cases. So you can see no quarantine is perfect. People eventually move through, and mix and mingle because people aren't able to, truly self-isolate or are non-compliant. But even that cursory effort is able to slow that spread. Eventually, resources are stretched and things break down, and eventually every dot in the simulation eventually turns purple. But the important thing to know about that is that the curve has changed shape. So it's longer, it's flatter. And that's what things like quarantine are able to achieve. This is what happens when you close the pub and no one goes out and everyone stays home. The less people move throughout the community, the less chance they have to bumping into each other, both literally but also infection-wise. And you can see that social distancing is as effective, if not more effective, than quarantine. So I want to stress the importance of social distancing essentially in every aspect of what we do. Keep to your 1.5 meters, take out where you can, be mindful of your environment and model that behaviour, because as healthcare workers, your patients not only look to you, but also as healthcare workers, we need you to be well, because we're going to have very stretched resources over the next few months. So just wanted to spin a little bit about managing a positive case. Ultimately, this will be driven by the public health unit in your local area, but I think it's important that you guys have an insight as to how this is done. So in a majority of cases, if you get a diagnosis, their illness will be mild. But certainly as a hospital clinician, if you're a general practitioner in Orange or in Blaney or in Molong, and you get a positive notification for a patient who is 75, diabetic, hypertensive, has myelodysplastic syndrome, and it's day 3 of their illness, I would like to know about it, please, because although the PHU will follow that, the public health unit will follow that patient up, I would also like to be very aware of that person so that I can touch base with them, or I can enroll them preemptively in, we will eventually have an outpatient program for these kind of guys, so that when they do decompensate, we have an early flag and we can move them into the hospital in a staged way, in a controlled way. We can plan our use of resources so that that's a more controlled method and an more easy manageable way of doing things, rather than if they rock up in an ambulance at day 8 and we've never met them. The PHU does get notified when you have a positive test, but like every other aspect of the healthcare system, they are under strain. If you get a lab notification, so if a microbiologist rings you and they haven't spoken already to the public health unit, the public health unit director has given me permission to give you all her mobile number and said, can you please text her about this positive test? That's the number there on the screen. And so the reason that is because if you have a positive test, for example, on a Friday afternoon, and it doesn't have time to filter through to the ministry's database such that public health can get notified, they might not find out until, at best, the Saturday morning, at worst, the Monday, and public health really needs to clamp these people's contacts, because particularly in smaller towns like ours, you can get so much bang from your buck if you just stop someone going to Ashcroft or stop someone going to Woolies in one morning. Because you can save one infection, you can save 5 infections, you can save 10. And so on the issue of public health resourcing, obviously they're in the process of surging their resources, but if you have the capacity, I would follow up your tests closely. So public health has committed to calling up the negative tests, but we find as a hospital it is smoother and faster for us to follow up our own tests. So we call those patients and tell them they are negative, and they can remove themselves from isolation in a setting where that's appropriate. Same with our positive cases. So de-isolation is a difficult one. The guidance has recently changed. I'll leave it mostly to public health, but essentially you now no longer necessarily need a negative test in order to be de-isolated. That Singaporean data is for hospitalised patients, where that still applies, but certainly in the community, if you're well and mild, they have a mechanism by which to time your de-isolation from when you got sick or how long you've been well, whatever is longer. I would stress the importance of PPE, these are some documents from the CDC about donning and doffing, because I'll skip to that bit. So because things to remember when you're planning is that the PPE will protect you, but only if you use it properly. So when they look at healthcare workers who get infected with COVID-19 or any other epidemic illness, overwhelmingly, nosocomial transmission to healthcare workers is because they either aren't using the right PPE from the start, because they haven't recognized the risk, or they're not using it properly. And particularly high-risk things are the doffing of PPE, when you take it off. So please take the time now, if you can find PPE, and you do have some left. If you don't, please try and sim it as you can, how to take it off and on. Because when you do eventually want to care for these patients, it's important that you do it safely, because you're all extremely valuable members of our healthcare team. So on that note, I think we as a hospital are in a practice mode at this stage. The number of cases on the ground is low, but now is the time to build the systems that you'll use to care for those people. Practice. What would happen if we had someone who was high risk in our practice? How would we manage them? How would we test them? What would we do if we got a call saying this person who came in yesterday and we weren't suspecting of, or is now in hospital and they think they've got COVID? Run through these things with your team, because that is what pandemic readiness looks like. Simulation and planning, not, we might put some people in here, we might put some people in there, I'm sure that'll work, which is, one of the easier ways, but the more dangerous ways of thinking about the problem. And so the whole concept I want to draw on here is this idea of the whole of health. So, we as the hospital do not work, as a hospital doctor, I don't work in a silo. You in the community don't work in a silo. You know that better than I do. And I want to take a moment to talk about our colleagues in residential aged care facilities. Orange has in particular, where I'm local, has a large residential aged care population. And I think I want to stress the value in reaching out to those communities and offering support where you can. Offering to talk to them about PPE resourcing, offering to talk to them about, similar things to what I've said about how they would manage a positive, how they would cohort. We're working on doing those things as a hospital, but as, general practitioners and community health people, you have established things, you have better relationships than I do. And I'd encourage you to think about how you can best assist those colleagues. And that goes for anyone else who might work in a healthcare setting that you help to service. Because if they go down, and there may be a risk of doing so, it's only going to fall onto other parts of the health system. And so the major thing about PPE is also, PPE is only necessary if you're in the room, and you should only be in the room if you need to be there. So, telehealth obviously is a large part of all your practice, and increasingly non-essential people are not entering, but it goes the same for consults and, any other patient care interaction. If this person doesn't need to be here, they shouldn't be here. Review what you're doing with things like students or, shared models of care for nurses. Do they actually need to be in the room? Do they need to see a patient, even if that patient is low risk? So I recognise I've gone a little bit close to my time, but I just want to break for questions. Hopefully we've left enough time. I'll spend certainly as long as I can, because I know that there's probably a lot.
Okay, so can you read that?
Yep, to be greater or equal to 38 degrees. It's more of a, so that's a comment from someone about the CDNA saying that the fever has to be greater than 38 degrees. That's changed on the 21st of March. I didn't know that, and this is probably a good example of the situation generally, which is that no matter how much I try to stay abreast of everything, because we don't get alerts when things change, we have the ability to be behind. So I assume that person is referring to the formal case definition. So I didn't realize they changed the case definition. We may all want to review that after this. Certainly the case, I'm on the New South Wales Health website now, and certainly case criteria says if any healthcare worker with in direct patient contact has a fever of greater than 37.5 and acute respiratory infection, they're classified as a suspect case. Possibly is that maybe different to what the CDNA says? I'm not sure. I have to take that as an action to go away and have a look at. So we might move on to the next question. Oh, yeah. Oh, yes. Thanks, Alex, for your question. So you mentioned nebulizers. Should be wearing aerosol protections when giving nebulizers. So I think it's important to talk about the role that nebulizers play in your practice and what elements of that are modifiable. Certainly the evidence from a respiratory illness, which is where I know it more better, so things like COPD exacerbations, for example, there is no evidence that a nebulizer is superior to an MDI with a spacer. We have a policy in Orange Hospital now, we do not use nebulizers at all, outside of nebulized adrenaline for croup. And so we've been able to reduce a large amount. If you do have to use a nebulizer for someone particularly who has a respiratory illness, I would put them in a single room as if you could, with aerosol precautions and N95 mask, and I would let that air settle for half an hour before we did an environmental clean. So another question, to clarify advice to healthcare workers, should we swab any healthcare worker with fever or respiratory symptoms? That's a great question, Alec. That's certainly in Orange Health Service, that's what we are doing. We are taking a very broad read of healthcare worker illness. Ultimately, it's a question for clinical judgment because it's outside of the case definition. If they can't tell you if they've had fevers or not, ultimately, the old guidance was an influenza-like illness. And so I think if someone's got clearly a post-viral cough or clearly a bit of rhinitis or clearly a bit of a sniffle, you can probably defer away from that because that's not how COVID-19 typically presents. But if someone's got a proper ILI with myalgia and, you know, a cough that's been going for 48 hours and a headache, but they don't necessarily know if they've had a fever, I would still swab them. Great question, Catherine, about the chest exam. So obviously I've never examined a COVID patient, but from the data that, well, no proven, but the data that I've seen says that the chest is generally clear. It's essentially non-specific clinical findings throughout, aside from maybe some tonsillar enlargement. You don't, even when they've got ARDS, they generally don't have much in the way of chest sounds. Is there any evidence for the use of face masks preemptively or shift for all clinical encounters? I know some, So great question there about the routine use of masks for all clinical encounters. There are some specialty bodies recommending this. Certainly the ultrasonography college or the ultrasonography body has said that they would recommend that their technicians use a mask for all exams, all patients, all the time. The problem with that, I think, as an infectious diseases physician, is that it predisposes that any patient at any given time could have COVID-19. And I think that's really problematic because it means that if we accept that in principle, it means that essentially the whole population should mirror our behaviour and the whole health system should mirror that behaviour. And I don't think there's a lot of evidence to support that, particularly because if you socially distance, droplets don't even reach the degree that a surgical mask could protect from. If you have to examine someone closely and they're asymptomatic, I think the risk is extremely low and PPE is in precious supply. The third thing to say about masks is that the data is relatively strong that if you do wear them, you actually in some ways are at more risk because you are constantly touching your face to readjust it, and that is a behaviour we would like you to avoid. Yeah, so NSAIDs, ACEs and ARBs. So that's a good question, David Howe. So ACEs and ARBs have been discussed mechanistically in a number of forums that I've seen. I don't pretend to have a good handle on the basic science elements, but essentially the recommendation is not to modify the treatment of your patients. Certainly one of our local cardiologists in Orange feels as though ARBs may be beneficial, but I have seen some recommendations to the contrary that perhaps they may worsen things. Ultimately, I don't think we have a good signal to do either, and so I wouldn't modify any therapy. In terms of NSAIDs, I'm aware of some French guidance and some guidance in a couple of guidelines not to use NSAIDs. Again, I don't think there's sufficient data to recommend that across the board. Ultimately, it's in our guideline that if you're providing someone analgesia or an antipyretic and they have COVID, not to give them an NSAID. I mean, there's no data for that. It really just seems like something we don't need, a treatment we don't need to give, so we just will avoid it while there's even the suggestion. Yeah, so that's, I think I've answered that one. So what's this one? Oh, sorry. Would you test for COVID in a patient who's returned from a cruise 18 days ago? Someone in the cruise is positive. She has no fever, but a tickly throat and a mild cough. She's not been isolating herself. Yeah, it's very difficult. So ultimately, the longest possible incubation period of COVID-19 described in the literature is 14 days. And that's where all the 14-day signals come from. If this patient is totally asymptomatic and was asymptomatic for the entire 14-day period between returning and the end of that 14 days, then I would not think they need a test. The caveat to that would be that there has been recent public health guidance that if someone who comes off a cruise ship in the last 14 days presents for a test, you have to test them, irregardless of any other questioning, basically. So all of the people who've come off the Ruby Princess in the last 2 weeks, if they come to see you, even if they don't meet the criteria, the public health advice is to test them. Now, the general view is that you shouldn't test asymptomatic people, and that's the exception. But if someone was 18 days ago, I wouldn't think there'd be a utility in doing a test. Yeah. So Louise, I've just got your question about physical exam findings and techniques. So basically, again, I think I spoke to this earlier, that the findings are generally extremely non-specific. There has been some concerns raised about ENT exams and whether it has a strong risk-benefit profile if you're going to look in someone's mouth and it's unlikely to be high yield, but it's routine, and you think they've got COVID-19, putting a tongue depressor in and having them cough all over you probably is not an advisable behaviour. I think the advice I've given to our emergency department through Mel Berry, Louise, is basically if you clinically think it's a necessary exam, you can do it with appropriate PPE, but I think it's just about having that prior decision point where you're like, well, actually, I've seen this kid cry and, you know, I think it looks okay. It's unlikely to be high yield. I'll probably avoid it. So that's AV sending in probably a link to what she was talking about earlier. Abby, I'll follow that up and I'll advise via email. Gloves and a mask, as that is all we have. Yeah, look, that's very, so Mary, that's Mary House just asked a question. If you have limited PPE, can you collect swabs wearing just a glove and a mask? And I assume you mean not using a gown. So there is some evidence that if you stand to the side and you are out of the field of droplets, that is a relatively safe procedure. I mean, my general view is that I would never put staff sort of wellness before resourcing. So if you can't collect tests through that means, then I think we have to think about alternatives for gowns. So there should be some guidance on the Centers for Disease Control website about some options you can consider if you don't have gown PPE. They're used for when they run low. If none of those things are suitable and you think that collecting the test is still something you would rather do than send them to another provider, then there is some data to support that. But I would stress that, you know, I would be deferring away from taking any risks if you can help it. Would reception staff be considered healthcare workers? Yeah, so in the definition, there's some guidance about what a healthcare worker is. It includes anybody who has frontline patient contact, and certainly anybody it's more about a risk profile, right? So if your staff are seeing 10 patients a day and they have an undetected COVID infection, that's a big problem. So I basically, you know, use the role of the healthcare worker more as a risk calculation than a strict definition of whether they're involved in patient care. Are there any healthcare workers affected so far in Western New South Wales? If I was aware of that information, I probably couldn't tell you. So for us trying to work out who we see in person who's doing telehealth, is there a role for a physical exam? So that's a good question. So, Catherine, I'd say no. Ultimately, there's a delineation between physical exam in so much listening to heart sounds, listening to the chest, and you've the ability to judge if someone's got, you know, increased work of breathing and dyspnea. There's always a role for sort of those kind of end of the bedograms, but I think you can replace, particularly if you have access to video, that's great. But if you don't have access to video, I think you can replace that through a number of relatively directed questions. Ultimately, I think telehealth's probably sufficient for a majority of patients. So Alex sent in a link. We allowed to follow that?
No.
Evidence about face masks in a clinical setting. So I might follow that. I might follow that link up, Alex, and I'll take that on notice. I'll get back to you. Are there any homemade options? Yeah, so Avi, it's a great question. So I mean, I would on the issue of homemade PPE and reusing of PPE. So the CDC guideline I mentioned earlier is a really good one. On their website, they'll talk about basically advice they've been giving American hospitals about what to do when you run out of masks and what you do if you run out of gowns or whatever. I would stress that, you know, I've had this thought a lot as someone who's planning for a hospital perspective about what happens when the masks run out and the cavalry doesn't come. I would stress that, you know, I'm sure you're doing lots of advocacy work and you're doing all you can to source masks, but ultimately, you know, I think that in a primary health setting where this person's test is non-urgent or semi-urgent, I would just put that burden back onto the hospital fever clinic or the private pathology collectors, and then I would advocate very strongly that you should be given the resources to do your job. I understand that seems like a very reductive reasoning, but I'm mindful that, you know, if I tell you to do something that is, or I recommend an avenue for PPE that is not necessarily endorsed or used or recommended only for use in a crisis, when we don't functionally have a crisis, there are masks around, then I think that's a concern. Yeah. Wilson just corrected that patient's been persistent for the past 14 days. So if they've had symptoms for 14 days, I mean, I think that returning earlier to the cruise ship question, then you know, I would just do the test, given that they have a relationship to a cluster. ACE I've already talked about. Yeah. Is there any evidence of spread through central heating or air conditioning? So no. So the good news about droplets, in terms of droplet spread, is that it's extremely heavy. So when you cough a droplet, it just falls straight to the floor, which is where this radius of 1.5 meters comes from. Aerosolized procedures in a hospital setting have a higher risk of spread through air conditioning and venting, and that's why we have to look at the exhausts in our single rooms, but certainly not in a routine setting. Shamim asks about any benefit of the early flu vaccine. I think that there'll be a discussion about the best thing to do with flu vaccines when they're available. I think ultimately, given the setting we're in, I'd be recommending flu vaccines when they're available to everybody who's eligible and those who are not, essentially. I think that they won't have any benefit in this setting, like preventing COVID-19, but I'd certainly love to see less influenza in the hospital come mid-June. Lucas Rouse asks, role for prednisone. So certainly the guidelines are that if you don't have a pre-existing indication for prednisone, so if you don't have an exacerbation of underlying airways disease or you're pulsing someone who's long-term steroid dependent, you shouldn't give prednisone to someone with COVID-19. There's no benefit and there's a theoretical, there's a signal towards risk. CPAP. So CPAP again is a big problem. So CPAP is an aerosolizing procedure. And so we've actually, just to give some guidance about what we're doing, you can't have high flow nasal prongs or CPAP or BiPAP in Orange Hospital in any setting. So that's COVID or no, any setting, unless it's approved by an intensivist. What advice to give other family members if one of them awaits for a COVID-19? Yeah, that's a good question, Jenny. So Jenny Zhang has asked a question about the management of contacts of suspects. So there is a mechanism within the public health guidance for you to notify the public health unit in a high-risk case to preemptively contact, trace and quarantine. I certainly did that yesterday when we had a very suspect case come through our emergency department. Ultimately, the view is that not every person you're testing needs their close contacts restricted in their movement. Certainly, most people wouldn't need that, but if you have a high-risk patient, so someone who's come from a known cluster, and you really suspect, has a typical illness, and you suspect that they have COVID-19, I would have no problems about empirically ringing the public health unit and saying, get in contact with this person. Yeah, so I'll direct that question to the primary health network in the daylight hours, Catherine. There is a plan to set one up. It's not operational at this stage. Criteria for clearing a health. So Lionel asked a question about if a healthcare worker has one negative swab, can you truly consider them negative? Yeah. So my view is that yes. The pretest probability is so low that a negative test is likely to be considered a true negative. The only time where we would retest people is if we've admitted them to hospital with a very high risk story and very high risk features, and the first test is negative. In the community, unless they had very strong risks, like they sat next to Peter Dutton or Richard Wilkins on a 6-hour flight, I would think that one negative test is sufficient. Should we turn off air conditioning, reduce flow? So, David, I don't necessarily think that we should be worried about air conditioning in a day-to-day setting. Certainly aerosol, if you're doing AGPs, you've got to worry about the airflow in that room. In a majority of cases, I'd say just turn the air conditioning off in that room. But for day-to-day practice, no, because the droplets are so heavy, they don't move around that much. If we administer flu vaccine now, so yeah, if you're going to do an early flu vaccine, there'll be some guidance about whether or not you should revaccinate them. Ultimately, the flu vaccine is unlikely to be available until early April. But if you do it, then it's unlikely to be funded for a second one. Should you do it again? I think you'd have to think about a risk profile and whether or not, and what the epi was doing and what the flu season had been like so far. Can they be given a flu vaccine if return to international travellers? So yes, if a traveller can be given a flu vaccine, yeah. So an international traveller can be given a flu vaccine if they've had no symptoms in the last 14 days. But my real question is, why is a returned traveller in your GP practice for a non-urgent appointment? They should be self-isolating or done by telehealth. So the lab has stopped doing, Ari Jalal has asked a question about the labs have stopped doing respiratory virus tests. So yeah, no, I appreciate that. I have a very close friend who works in the Douglas Hanly Wong Laboratory in Macquarie Park, and basically they've been forced to do that solely because they just need more time in the day to do COVID tests, essentially. Ultimately, a positive test for enterovirus or rhinovirus does not affect someone's presence or absence of COVID-19. Co-infection is common, and although I get, as a clinician on a pragmatic level, you'd be reassured to see a positive flu swab, ultimately what it comes down to with COVID is that test positive or negative. Private flu prescriptions are already available. Thanks, Alex. I didn't know that. I'm slumming away in the public hospital. Lucas has asked about sunlight sterilisation. So yeah, there's some data that heat above 40 degrees and UV light will help to denature things. Ultimately, I wouldn't use it to do things like reuse masks or reuse gowns. But if you're building, as some colleagues of mine, of ours, in other hospitals are doing, if they're building flu clinics that involve outside spaces, having some sun exposure would only be beneficial, because the drying of the liquid also helps to fix the droplets. Okay, perfect.
Thank you, got it.
To be all. Wow, that's great.
Yeah.
Again, I apologise if there was an error about the fever definition, AV and others. I'll chase that up and I'll advise via email. And Alex, I'll also have a look at that link you sent about masks, because I tell you what, it's the masks thing that keeps me up at night. Oh, here we go. No, that's not it. It's all right. So if there's no other urgent questions, I might leave it there. And
yeah, so I'd just like to say, we got another one coming.
Oh, go ahead.
A really big thanks to Jake for spending so much time with us tonight, answering so many questions. I'm sure people are going to have ongoing questions as this pandemic continues. And like Jake said, if everyone's working together, hopefully we get there in the end. So we've gone a little bit over time, but thank you all for dialing in. And if you can take some time to do the evaluation at the end. I've also asked for any further learning that you might need. So please take some time to fill that in, and we'll do our best to meet all your needs. Have a lovely rest of your evening, and we'll talk to you all again soon. Thank you.
Nice.
You